minutes.
Okay, so at this time, we want to discuss the post-cardiac arrest care algorithm. By post-cardiac arrest care, we mean when cardiac arrest management has been stopped, it does not end the resuscitation there. You know that? There are a set of activities you need to also do to prevent the patient from re-arresting again. And that's why you notice that most patients who have arrested, they don't even last for long before they expire again. And this time it's always bad because the resuscitation team have not considered or probably integrated what we call the post-cardiac arrest care. Now, there are 5 links in the chain of survival. The first, like I talked about, is immediate recognition of a possible cardiac arrest. On your wards, that patient who is on the bed, you come around, you're doing your ward rounds or hourly rounding of a patient, and you see this patient making agonal gasp, or the patient has had this, you're having a subjective concern about the patient, or the patient is having breathlessness, tachypnea, or with increased effort with breathing. Now you've activated the rapid response team, and after a while the patient arrests. Now you started CPR. You see, we are now in the second link. Early CPR. We've started CPR in the second link now, right? You keep doing it, and after some time you've considered to defibrillate. Rapid defibrillation, which is third link. After some time you consider to give medication, right? That is effective advanced life support. Once medication, oxygenation comes in, and even the manual defibrillation, once it comes into play, it is advanced cardiovascular life support. That's effective advanced life support. And then after everything, ROSC is achieved. When there is now a pulse, then you start your integrated post-cardiac arrest care, which we want to discuss now. So we have the post-cardiac arrest care algorithm. What do you do for that patient who has had a pulse? The heart is now beating after you have successfully resuscitated him. It does not stop.
32 to 36.
Okay, so Dr. Muda is encouraging that we induce what? Hypothermia, right? I'll talk about the induction here. The first thing you need to do, earlier in this course, I talked about the primary assessment. Is that right? That there are 2 times we follow the primary assessment. The first is when the patient is conscious, and the second is
unconscious with ROSC.
Unconscious, but ROSC is achieved, right? Very good. So now that brings us to the primary assessment again. A, B, C, D, E. A stands for what?
Patency and maintenance.
Airway. You need to check for the patency of the airway, right? And if it is maintainable. What is B?
Breathing.
B stands for breathing. What are you looking out for breathing?
The
The rate, effort, chest pressure. Are there retractions? Are there suprasternal retractions, intercostal retractions, or subcostal retractions, right? E, chest expansion. Is it equal on both sides? Or are we having more entry on the right, diminished on the left? S is breath sounds, and O is oxygen saturation. So I use the acronym REPESO. Okay? What about C?
circulation.
Circulation. What are you looking out for in circulation? The color, right? The pulses, both peripheral pulse and the central pulse, are they equal? Or do we have a weak peripheral pulse on this patient and a bounding or a strong or even fair central pulse? R, the heart rate, right? So what else can we assess for in circulation? the capillary refill time, which is less than 2 seconds, right? The blood pressure and the heart rhythm. It's expected that everybody learns how to understand and interpret ECG. Okay? What is D? Disability. What do you have with disability? AVPU. So here, in this case, once ROSC is achieved, you probably want to start asking, is the patient comatose? Is the patient comatose? That's a very big question you need to answer. So you need to stimulate the patient. Hello, Mr. Johnson. Ask Mr. Johnson if he can grab your fist. Hello, Mr. Johnson, can you grab my fist? And he's unresponsive. You can also do the sternal rub, okay? Mr. Johnson, and Mr. Johnson is not responsive. You can also stimulate the nail bed with the pen, okay? What is E? Exposure. So what do you look out for under exposure? The temperature, right? Etc. So this is a basic thing I look out for here. Under disability also, I want to find out the GRBS. Very important, is that correct? Good. Now, Dr. Muda, we talked about the temperature, right? So, we talked about hypothermia. Very important. Let me show you now. There are basic things you need to find out before you initiate hypothermia. In the previous guideline, we considered it as therapeutic hypothermia. That's what we called it, therapeutic hypothermia. But outcomes were worse than what we were having worse outcomes with induction. We called it induced hypothermia, right? But in this present guideline, it's called therapeutic hypothermia, or what we call the targeted temperature management. That's what it's called actually. Targeted. How do I mean? Previously, remember we talked about hypothermia being one of the reversible causes of cardiac arrest. And now we are saying we want to still cool this patient. How contradictory is that? But I will tell you, it's not contradicting. Up until this moment I am speaking with you, the only outcome that has been found to improve neurological function of a patient after a cardiac arrest is cooling the body below the normal temperature. Up to this moment I'm speaking to you, there is only one intervention that has been found to improve neurological function of a patient post-cardiac arrest. What is that? Cooling the body temperature. So what is the recommended temperature to cool?
32 to 36.
32 to 36 degrees Celsius, okay?
For 24.
For at least for not less than or equal to 24 hours, okay? Now, I'll talk about this in depth now. There are basic things you need to find out before you induce this, before you start your targeted temperature management. In this guideline, it is now called targeted temperature management. It is called that because we want to open up a strict temperature chart to ensure the temperature is not going so high or the temperature is not going too low. That's why it's called targeted temperature management. You keep the temperature within this range. Because if it drops below 32, gets to 30, the patient can relapse again into cardiac arrest. If it goes beyond 36, getting to 37, 38, 39, the patient can rearrest again. So you keep it within this range. That is why we call it TTM. So not just hypothermia, but let me put it below targeted temperature management. That's the preferred term for it. Okay, so what do you need to find out? What are the informations you need? You need one, where is it? The blood pressure. This P, that's the first thing you need to find out, the blood pressure. What else do you need? What other information do you need? The temperature, right? To induce this, you need the temperature, you need the blood pressure. and you need the breath sounds. Sounds, pressure, temperature. Why? And you also need the level of consciousness. These are the 4 parameters you need to check for before you start your patient's on targeted temperature management.
In this way, patient must be ventilated, mechanical ventilation?
Not necessarily.
Not necessarily.
No, the patient can even just be bagged. You might be bagging the patient, and as a team leader or even as a team member, you should be able to auscultate for breath sounds, right? So here is the stethoscope. Now, may I say this in this class? I want us to taper down at the use of fluid. You see, fluid we give to patients. Yeah. It can either help the patient or kill the patient. Why most resuscitations are not going so well is because in the course of our goodwill or our actions, we are so generous with the fluids, not minding what is happening at the basis of the lungs. And that patient tends to develop what? Pulmonary edema. And the patient tells you au revoir. I'll explain this. So after you found out this, so why do you want to find out the breath sounds? The same reason I've just mentioned. In cardiac arrest, this is what happens. The heart is not pumping, is that right? Let's assume this is the heart. Now this is the aorta. These are the vessels, okay? The peripheral vessels, or even the central, depending on what you might prefer to term it to be. This is the heart. This is the septum. Now, in cardiac arrest, the heart is just like this, in asystole, right? Cardiac inactivity, is that right? No activity. In PEA also, pulseless electrical activity, the heart is like this. So if the heart is like this, let me ask you a simple question. Why do you give fluid to a patient who has arrested and you see asystole? You now order for fluid immediately. Does it happen? It happens, right? The first thing you remember when you see a patient in cardiac arrest, aside from starting chest compressions, you will tell your colleague, get normal saline, NS, or you get Ringer's lactate, right?
Because there is vasodilation, all the blood in the periphery. We want to make venous return more. To raise blood pressure.
Okay, you all give fluid, is that right? We give fluid, true? Really? We give, right? Yes. We know. Let's discuss as friends, right? We give fluid, is that correct?
Yes.
Is fluid part of the algorithm? Look through your cards. Do you have fluid there?
No.
So why do we give fluid? Fluid is not necessary because this is exactly what happens. When you give fluid, sometimes you even open it and hold it like this, is that right? You press it to infuse it very fast, is that correct? Why? You are loading.
Sometimes you don't know anything about the patient. He dehydrated, hidden bleeding. So?
Even if the patient is bleeding, if he's dehydrated, he could be in shock. If it is a cardiac arrest, you have seen a flat line, you have no need for fluid. Just do what you have to do. There is still some blood left in the heart you need to perfuse the body with. Keep doing that until ROSC is achieved. Most patients, when ROSC is achieved, they come up with a pulmonary edema, which is even worse than what has happened, and you start battling with a lot of things. So please, do not give fluid during CPR. It's not necessary at all. Just be doing what you're doing. Shock, if it's a shockable rhythm or whatever it is, even if it's like this. In VF, you still don't have any need for fluid. In PVT, pulse-like ventricular tachycardia, is this enough to cause cardiac output? No. So why do we give fluid? You're overloading this patient. These are the things that cause death. So we can actually save more lives, right? Thank you. Having known that, so we are talking now about the targeted temperature management. You need to listen for bilateral crackles. You need to confirm that the blood pressure, the systolic is below 90. You need to confirm that the patient is comatose. If the patient is conscious, please do not give him cold fluid. What is the temperature of the fluid to be given? What is temperature? 2 to 6 degrees. We have fridges in our facility which will record temperature, right? That is the fridge that should contain the normal saline you will give to the patient once ROSC is achieved. Your saline, your Ringer's lactate should be in that fridge. So you're giving cold fluid, almost getting to freezing point. So it means it is painful. You can't give somebody who is conscious very cold fluid like that. The patient will box you, I'm sure about that. It's painful. So you need to ensure the patient is comatose and then find out the temperature.
Airway must be secured, comatose?
Absolutely. Yes. Airway, you will follow all this pathway.
I mean intubated.
Sure, you have to consider advanced airway management, AAM. Consider it. It is very important, right? Aside from all these wonderful things you're going to do, I am also talking about the induction of hypothermia, what we call the targeted temperature management in this present guideline. Okay? Is it clear? Very good. After this, you also need to retrieve the blood. Remember the other time we talked about CPR you started CPR, you have defibrillated, you have gained IV access. You need to draw blood, right? So now it's time for you to retrieve the blood studies, the blood reports. So, diagnostics, which entails blood reports, it entails chest x-ray, it entails ECG, a 12 lead ECG, not just the lead 2, read them. A 12 lead ECG. You need to, it also entails what? What else? ABGs or VBG. ABG or VBG, venous blood gas. Okay? And then you can still reconsider the H's and T's to refine your diagnosis. You can rule in or rule out, and then you need to seek expert consultation. And then you transfer the patients to either the ICU or the coronary care unit, CCU, or where else if the patient needs to go to the cath lab for reperfusion therapy. So this is your post-cardiac arrest care algorithm. Is it clear? Any question? Good? All right. Thank you so much for listening.